Hi, I'm Annemarie Thompson, and I'm a professor of anesthesiology, medicine, and population health sciences at Duke University, where I practice cardiothoracic anesthesiology and critical care medicine.
My name is Kirsten Fleischman, and I'm a non-invasive cardiologist and an outcomes researcher. I'm also a professor at the University of California, San Francisco, where I serve as an assistant chair in medicine and associate chief in cardiology, and as a medical director, specifically of our adult cardiac stress and ECG laboratories at UCSF Health.
My name is Nathaniel Smilowitz. I'm an interventional cardiologist and clinical investigator and assistant professor at the NYU School of Medicine in New York, as well as the VA New York Harbor Healthcare System Manhattan campus.
I'd like to ask Kirsten and Nathaniel to comment a little bit on the algorithm and what they find new or interesting, or what clinicians who are taking this in for the first time, what they would suggest that they focus on.
One of the things that I think is new to our algorithm is the preoperative biomarker risk assessment. We've learned over the past decade that relatively simply obtained biomarkers can help us to risk stratify our patients further. And so you'll see that traditional testing, for example, stress testing, or now CCTA, comes a little bit further down the algorithm. I really think that that is an area for people to focus on, and if they're not particularly familiar with these biomarkers, I encourage you to read the guideline because it goes through in detail the data that we have on these points.
I think that's a great point, and I completely agree. I think that's a major change in the guideline. It really does de-emphasize the dedicated cardiac testing, which is expensive and can lead to downstream implications that are not necessarily advantageous to patients. So that the biomarkers really do add quite a bit. I think the risk modifiers in the box really is a major change in how we think about risk assessment for these patients. Many of the risk calculators don't include things such as recent stroke or the presence of a pacemaker or a defibrillator. And those considerations really do impact perioperative care and may require additional team discussion before you send somebody to the operating room.
I think one of the major changes in this whole algorithm is the algorithm from 2014 really looked to identify patients that were at increased risk of a coronary ischemia or myocardial ischemia, whereas I think this takes a more holistic or comprehensive look at cardiovascular disease.
I also wanted to call out the myocardial injury after non-cardiac surgery and the troponin surveillance at the end of this diagram. This is something that was added to the flowchart from the 2014 perioperative guidelines. And I think this is an important consideration because an elevated troponin in the postoperative setting can really identify patients who may have subclinical cardiovascular disease and are at increased risk of long-term, short and long-term adverse outcomes. Myocardial injury occurs in about 20% of patients, and it may change the care of somebody who doesn't have known cardiovascular disease at the time of surgery.